We now invite Dr. SUVEN BHATTACHARJEE. You just heard his entire course on a small pupil management. We'd like to hear some more tips from him, how to handle these cases with various devices.
Thank
Dr.
you.
SUVEN.
Thank you, Professor Titial, sir. It's a privilege and honor to be in your course year after year. I'm SUVEN BHATTACHARJEE. I'll be talking about dealing with the small people. And I do have a financial interest in the BHEX, and there will be a significant overlap between the last talk and this because you can't take BHEX out of small people and small people out of BHEX. So dealing with the small people is all about anticipation, identification, and management. So when the pupil is reduced, size is reduced to half, it's a little bit of geometry, simple geometry, school elementary geometry. When the pupil size is reduced to half, the surgeon's viewing area is reduced to a quarter. If the surgeon can't see the cataract well, he can't operate safely. And that is a serious disaster. So you need to ask yourselves, what would you prefer? We've all burnt our fingers. We're all great surgeons. We've burnt our fingers trying to do small people's phacosurgery without devices and taking a call a little late or not taking that call. Now, if you are undergoing a cataract surgery and you have a 4mm non-dilating pupil, what would you like your surgeon to do? Use a pupil device or use the skills alone? Rest, I think you have the answer. So can pre-op pupil size be an indicator of possible IFIS or not? This paper published quite some time back in 2011. The conclusion was that for a pupil 7mm or smaller, the risk of IFIS existed regardless of alpha blockers. So tamsulosin is not the only issue. And that is the long list of drugs which can cause IFIS, including common conditions like hypertension. I mean, every patient, if not, every alternate patient has hypertension. So no amount of history taking can prevent surprises. And intraoperative myosis is unpredictable. Let's come to terms with that. The good news is that more and more surgeons have reduced their threshold for using a device because of the unpredictability of IFIS and the exacting patient expectations. It's a litigious society now. And we do know that premium IOLs can be very unforgiving. So you don't want to take chances. So I believe that a disciplined approach is very much required when you come to small pupils. Whether you're using iris hooks or pupil expander, doesn't matter. Treat every eye as a potential IFIS candidate. Reduce your threshold. Please have a stock of devices in your OR or operation theater. We must know how much viscoelastic and where to inject it. We need to distinguish the elastic from the non-elastic rigid pupil, and you need to have a handle on how much pupil size you really require. It's bigger is not always better. And the choice of pupil device will very much depend upon whether you use OVD alone or iris hooks or pupil expanders, the elasticity of the pupil, and how you wish to tear the rigid pupil. IFIS, actually, no device will work. I'll tell you about that. So now, injecting viscoelastic to inflate the anterior chamber and expand the pupil is a very bad idea because you're plastering the iris to the lens surface and leaving no space for the pupil device. So inject viscoelastic there under the pupil margin and keep the anterior chamber shallow so that you lift off that pupil margin a little bit to facilitate placement of the pupil expansion device. So keep the anterior chamber shallow. Overfilling of the AC is counterproductive. Use viscoelastic under the pupil margin. This paper by Chang and Campbell in 2005 told us about IFIS, and it said that unlike the non-elastic myotic pupils, the IFIS pupil immediately snaps back to its original size following attempts to stretch it. So small pupils are of two types, elastic or non-elastic. The elastic pupil is like a rubber band. You can stretch it. Any pupil expander will work. The rigid pupil is very much like a string. It's not going to stretch, so you will need to tear it. What you use to tear it is up to you, whether you use a bulky expander like the Mulligan ring or the I-ring or an APX or the BHEX, or use Kugelin hooks and then use a delicate device like the BHEX. So you could check the elasticity of the pupil before you start out the case. As soon as you've done your paracentesis, inject BSS or Englactate to the side port. If that pupil expands momentarily, you know that it is an elastic pupil. You really don't need to bother too much. But if that pupil does not expand and it doesn't budge actually, then you know you're dealing with a rigid pupil. It's a fibrous pupil. You need to stretch it with 2 Kugelin hooks. Again, it's your choice. 2 Kugelin hooks, I believe, gives you a very controlled, you don't need to stretch limbus to limbus, and you have a good cosmetic effect at the end of the day. You have control. You have a handle on the pupil size. So mechanical dilatation of the pupil, in IFIS, it's no good. If you have a rigid fibrotic pupil, yes, it's effective. To facilitate probably use of a device, or you can, if you think that stretch is good enough and this pupil is not going to come down, so pretty good, go ahead. So we have iris hooks and retractors which we've been using for a very long time, and we have the pupil rings like the Mulligan ring or the BHATTACHARJEE pupil expander now. Now, I have not used the iris hooks for many, many years now for obvious reasons, but I will pull out a video from my archives and I'll try to show you a few steps. So I like to do the side ports first, the 3 and 9 o'clock when I'm using a superior incision. I'm sorry, I'll keep. So, and visco from, sorry. I'll let it run. What's the matter? It's hanging. I'll start again. I'll come to that slide. I'll come to that slide, don't worry. I'll let that video run without any interruptions so that we don't have a mess. Yeah, so yeah, I'll do that. Okay. Go to duplicate sites. Okay. Again, the same problem. Okay, so I'll not touch this video now. So I make the side ports first, and I don't want to overfill. And the paracent is in a clear corneal incision. I leave a small conjunctival mark, otherwise it's very embarrassing. You can't find your paracentesis. That's when I used to do the iris hooks. And I like to make sure that the stopper is well retracted. Otherwise, it's again embarrassing. You've gone halfway through inside, and then you realize that the stopper is not pulled back. So pull back the stopper. Do not try to, this is an overstretch. This is an overstretch. This was in the times when I used to do the iris hooks. And I place a phaco incision much later. Please keep a control on your capsular exercise. Don't get carried away by the size of the pupil expansion. Remember that the pupil margin is now a little anterior at the limbal plane, and it is often antiflexed. So every instrument that goes into the eye has to circumvent that kind of antiflexed and elevated pupil margin. For removal, you can just hold that stopper, put it back, push that device inside, and just pull it out. It momentarily stretches. You really don't have to do any heroics of turning and twisting. Just need to, that nylon hook will just kind of, or polypropylene hook will just straighten for momentarily. Now, iris hooks do have a downside. I'm not anti-iris hooks, but these are genuine downsides which I found. So multiple corneal incisions, yes, theoretically the risk of infection is high. We do have iris sphincter tears, and I believe that in a square pupil, the corners are wasted space. We are going to work within the rexus, so why do you need the corners? The anterior chamber gets cramped because your pupil margin has been elevated to the limbal plane, so you are a little stuck for space, and that could lead to iris trauma and corneal endothelial damage. And this publication in 2019 in the JCRS suggested that iris hooks do take a longer time than pupil expanders, 14 minutes for consultants more, and 24 minutes for trainees. And of course, we could have a permanently dilated pupil, which could be very annoying for multifocal patients, and of course, cosmetic issues. So we come to pupil expanders like the BHATTACHARJEE. It's a thin device. It's got flanges, notches, and it's got tabs for holding. It's very thin, 75 microns, and as thin as a human hair. Simple design, user-friendly, tissue-safe, affordable too. What's important is that the housing is transparent so that you can hold it with the BHATTACHARJEE 23 gauge forceps, and entire travel, you can see the device through the entire travel. It's never kind of invisible, so you know what the device is doing. Unlike when you're using an injector, you don't know whether the device is twisting, turning, somersaulting inside the injector. The most important difference between the BHATTACHARJEE and any device pupil expander that's been there in the past is all the devices were biplanar. So this is the device and this is the pupil margin. Whereas the BHATTACHARJEE, the device is in the single plane, it's super thin, and the iris margin, the pupil margin kind of bends at the notches. The pupil margin straddles the notches, and that kind of lets us obviate that injector. How big do you want the pupil to be? If you are assured that you're going to have a 5.5 pupil which is not going to come down on you, what's important is the coming down, not the size of the pupil. All of us are experts at doing surgery with 5.5 pupils, and the BHATTACHARJEE allows you to do that. If you're using iris hooks, I would strongly encourage you not to go beyond a 5.5 and keep a handle on that. Now, this is a rigid pupil. I just showed it earlier. Rigid pupil, pseudoexfoliation, Dr. Deepak Megur, little bit of viscoelastic under the pupil margin, and That's a 5.5 pupil, nothing more than that, and this is a pretty hard cataract. All you need to do is chop that nucleus into small fragments, and you are pretty comfortable getting away with whatever technique you use. You need to just get that into smaller fragments, and thereafter it's an easy job. IFIS. Now, all of us have our own personal preferences. Most of us would say, I would prefer iris hooks. Some people will swear by the Mulligan ring. Others would swear by the BHEX. Actually, for me, IFIS, there are two components. Meiosis, iris hooks or pupil expanders provide a constant pupil size, good visibility, safe phaco, nothing more than that. Iris prolapse, no device works. It's the severity of the IFIS that day, that eye, which matters. Whether you're using hooks, pupil expanders, anything. It's that day, that eye, how bad it is. So for IFIS, I would say any device which is thin and can go in and out of small incisions, whether it's iris hooks or pupil expanders, it's your choice. So that BHEX can be taken out through a 1 millimeter side port, and that's a big blessing when you're dealing with the iris prolapsing through all incisions, in main incision and side port. So intraoperative meiosis, the advantage with the BHEX is, I'll take just half a minute more, and where you can actually have instant confirmation. As you tuck those flanges, you carry it to the periphery, and you have instant confirmation whether you engage the capsulorhexis or not, because the notches are entirely visible. With the Mulligan ring or other devices where the engaging part is on the sides, you cannot have a direct visibility whether you are engaging the capsulorhexis margin or not. And this is a wonderful video which is available at the American Academy website. This is by Dr. Michael Henry, on the guidance of Dr. Deepak Paul Edward in the University of Chicago in Illinois. And this is an eye with a tube shunt and a very shallow anterior neovascular glaucoma, and it was easy to use the BHEX with a single incision tucking all the flanges. That could be very helpful in complicated cases like this. So for me, the choice of device, intraop meiosis, is either iris hooks or BHEX, anything which helps me not catch the capsulorhexis margin. Choice of pupil expander and subluxus cataract, absolutely no doubt, iris hooks. I would not use my own BHEX because iris hooks allow you to use asymmetric pupil dilatation for the area where you have subluxation to give you better visibility. There's nothing like more important than visibility. I'd strongly encourage you to take a look at this tips and tricks on BHEX, which is available on our website, and this is another tips on phacoemulsification. Thank you very much for your kind attention.
Thank you very much, SUVEN. Wonderful, wonderful concepts and the device that you have. You make all of us